This is a case of a lower right first molar with a couple of decades actually worth of history. As far as the patient could recall, initially when she was quite young, endodontic treatment was attempted and gave up on. There was a later attempt, so the tooth, when I found it, was in quite a bad way, even if the tooth was completely asymptomatic at this point. The obturation and part of the core looked like it consisted of IRM or some type of Eugenol based temporary filling material, and it was covered with a composite filling. And this Eugenol based material was forced all the way, almost halfway down the roots. The only way to safely remove it was with an ultrasonic device, and it worked out quite nicely. I used to start X number 3 initially, but when the space became too tight, I switched to the U file from NSK. This is on an NSK Varios scaler. Previous attempts at locating the canals really made a mess of the anatomy, so we didn't have anything to go by. I spent the majority of the first appointment to hunt for the canals using a combination of slow carbide burrs and ultrasonic endodont tips. Distal was easy enough located, but the mesials were severely ledged. As with any ledge, I pre-curved the files, and by using the correct approach angle, I could successfully bypass both the ledges. You'll see in a minute when we irrigate how the irrigant disappears from the buccal canal if we suction it out through the lingual. Distal was a single canal, although I heavily suspected a double canal, but it turned out that the extra mark that you might see to the top right of the actual canal there was created at one of the earlier attempts at root canal treatment. The flare-up the patient experienced when we disturbed this chronic irritation was so acute that she actually had to get intravenous pain medication from a hospital facility. A lot of patients would have had the tooth removed very promptly, but she hung in there, and as a result of that, I was able to obturate. I'm using a vertical condensation technique with heated GP. The distal canal had a huge apical foramen. It was in the region of size 50 ISO. This was also the canal that caused the flare-up. It constantly wept exudate when I saw the patient on her second appointment, at which we remedicated the tooth. Mesially was also a challenge because the two mesial canals join each other, but also the curvature at which they join, combined with the damage that was already done, made it quite hard to ensure that we don't have any air pockets within the obturation material. Filling out the core of the tooth is also a debatable issue. In my view, the internal anatomy was damaged so badly by previous attempts that there are too many undercuts to consider a lab fabricated post and core made of metal. My second consideration was the fact that this tooth was probably for a couple of decades exposed to Eugenol. Long-term exposure to Eugenol might have a detrimental effect on the bonding of the composite materials that we use as a core. I would have loved to use the composite materials because of their strength and because they are so easy to use, but in the end I opted for a glass ionomer in the form of Chemfil rock from Dentsply to fill out the tooth and create a core onto which we can bond the crown. The internal surface is etched just to remove the smear layer and the last of the microscopic debris that might be there. I left the GP slightly submerged below the actual orifice, and I took care to make sure that these little cavities were filled out with material before I packed the rest of the core. The material I used was Chemfil rock from Dentsply, and you have to be quite fast if you want to add layers in between to make sure that it doesn't set on you. As you can see, the distal, that's about perfect, and then on the mesial roots you can see the GP joining up and a slight puff of cement that extruded through the apex. Thank you for watching.